Okay, right. So today we are going to complete our arthritis group of disease, right? So even though it is a continuation of yesterday, the approach slide I hope you have seen on the Facebook post, and just we have to continue with the arthritis disease. So don't worry, can start from here that we are going to have two diseases today to discuss. One is rheumatoid arthritis and other is the SPA, the group of spondyloarthropathies. These are the two topics we want to discuss today, right? So let's get started. So today we are going to start much more commonly. Yes, today we are going to be fast. From today, tomorrow, day after we'll be fast, because I think we are now in synchrony with the way of teaching. So it's the same order we want to follow with arthritis disease. Okay. So the most common cause of inflammatory polyarthritis is the rheumatoid arthritis, right? So the first line, let us start with. So rheumatoid arthritis, the epidemiology, it is 20 to 40 years, female dominant disease. See, the point is simple, that we have planned the sessions in a way that we are to cover these topics. So today the class will continue till rheumatoid arthritis and spondyloarthropathy is completed. Whether it is 9:30, whether it is 9:45, we will complete the topic today. Right. So we are going to start from here. That first point you are to write. Rheumatoid arthritis, it is a disease affecting young to middle-aged female. The disease affects young to middle-aged females are affected in rheumatoid arthritis. When you look at the risk factors, the cause is idiopathic, but there are again risk factors like we saw in the SLE. We saw risk factors. So we are going for here that infection can be a risk factor for the development of rheumatoid arthritis. It can be infection, can be a risk factor for the risk for rheumatoid arthritis. And the two important infectious agents associated are one, mycoplasma, and number two, Epstein-Barr virus infection. So two infective agent, one, mycoplasma, and two, Epstein-Barr virus infection. Okay. So app is hanging is the constant message I'm getting. So just take a minute to restart. Okay, shut it and restart. So don't worry, we are going at a comfortable pace, right? Okay. So infections can be there. The second important risk factor is the genetic association. Second important risk factor is the genetic association. So genetic association you can say with HLA-DR4, or more specifically we can say HLA-DRB1. We can say specifically HLA-DRB1 is the genetic association with rheumatoid arthritis. So please remember, this is an important point here, that whenever a disease has a genetic association, we all feel the disease will be hereditary. That means family history should be strong. That is the common thought. So hence we say that because there is a rheumatoid arthritis has got a genetic association, it is likely to have a strong family history of arthropathy is what we want to see. But here it is not the correct statement. In spite of having a genetic association, there is no family history in majority of the patients. So write this point here, in majority of the patient. Unlike spondyloarthropathy, this is the first slide. Okay, this is the first slide. Unlike spondyloarthropathy, the associated gene has got poor penetrance to the next generation. So the gene HLA-DRB1, which is associated with the risk of RA, has got poor penetrance to the next generation. And hence, most commonly, rheumatoid arthritis is a sporadic disease. Most commonly, the rheumatoid arthritis is a sporadic disease. That means there is no family history in majority of the cases. Sporadic disease means there is no family history in majority of the cases. So many RA patient will be the first patient in the family to get affected by the disease. Family history is not common. And what are we highlighting? Comparison. We are comparing it with the topic of SPA, spondyloarthropathy. We want to compare that, please. So we have started with the first slide only today. Rheumatoid arthritis is a disease affecting young to middle-aged female. Risk factors can be in the form of infection and genetic association. Infections associated with risk of RA are mycoplasma and Epstein-Barr virus infection. The genetic association is HLA-DRB1. The genetic association is HLA-DRB1. But in spite of genetic association, family history does not occur. Family history does not occur because the associated gene has got poor penetrance. Associated gene has got poor penetrance, and hence most commonly rheumatoid arthritis is a sporadic disease. Most commonly rheumatoid arthritis is a sporadic disease, right? So let us just 1 minute hold on. Everybody is having worry with the up hanging. Let's confirm with the center. Okay, the app is working well on my phone. Yeah, app is working well. There is no problem. Okay, so there might be few who are having the problem. We'll try to sort that, or maybe we have to just take it from there, right? Okay, chalo. So next slide. So what we have got it now, in all the diseases that we have discussed, we have started with the definition, epidemiology, etiology, pathology, risk factor. After the risk factor and pathology comes the clinical feature, manifestations of RA. Comes the clinical feature or the manifestations of RA. It is what we want to know, right? So what is this? Let's divide the points here. Yesterday in our index approach slide for arthritis syndrome, we have written under rheumatoid arthritis that it presents with the predominantly articular symptom. We have written yesterday that rheumatoid arthritis presents with predominantly articular symptoms. That means joint problem is the main presenting complaint. But there are also few extra articular features that can occur with the disease. There are also few extra articular features that can occur with the disease, right? So everybody, the doubts I will answer at the end of this topic. Okay, so just continue with the thing. Let us continue with that thing. So predominantly articular symptom. Let us review what we studied yesterday. Yesterday we classified, we understood approach to arthritis. I want you to recall that and just put it in a proper manner. What we saw yesterday? Inflammatory polyarthritis, which is how? Appendicular dominant. Inflammatory polyarthritis, which is appendicular dominant, which is symmetrical, more commonly symmetrical in the involvement. Polyarthritis, now we know the definition, more than equal to 5. We know the definition, more than equal to 5. Polyarthritis affecting the small joints of the hand. So yesterday in our approach table we made, I hope you remember, we said that whenever patient comes with arthritis, we first divide whether it is degenerative or inflammatory. Degenerative arthritis exclude. If it is inflammatory arthritis, you count the number of joints affected. If number of joints are more than equal to 5, you label it as a polyarthritis. In the polyarthritis, most common cause is RA, but the involvement is appendicular dominant. We said appendicular dominant. And below that, we also said it is symmetrical. majority cases are symmetrical, affecting the small joints of the hand. Affecting the small joints of the hand that we have. So namely, which are the small joints affected in RA? Which are the one affecting small joints? Which are the small joints affected? Namely, RA affects the wrist, metacarpophalangeal joint and the PIP joint. So RA affects that it can affect the wrist joint, the metacarpophalangeal joint and the proximal interphalangeal joint. So RA can affect wrist joint. Again, please focus on what is been there. I don't know. I'm very surprised, sometimes at the doubts you all have, whether it can be this, whether it can be that. Why don't we first learn what I'm telling you? First, let us learn that and then we will come back to your doubts. Okay? You are only getting distracted. Okay? So commonly there is no order. It is all simultaneous. And how does it matter? First, what is taught? Let us try to understand that as a concept here, broad picture. Then go into the details if you still want more interest oriented learning. So typically it is the wrist joint which is the onset. Typically it is the wrist joint which is getting swollen. Then it can also affect the knuckles. Knuckles are also called metacarpophalangeal joint. And it can also affect the PIP, that is proximal interphalangeal joint. The proximal interphalangeal joint it can affect. So this is the most common pattern of joint involvement in RA. What we are writing is not the only pattern. So there were few doubts yesterday. Can RA be posi-articular? Answer is yes. Can it be asymmetrical? Answer is yes. Can it affect large joint? Answer is yes. Because I told you on the first day that doctors read textbook. Diseases don't read textbook. Presentation kaisa bhi ho sakta. But does not mean that we learn the atypical one first. What we read in medicine is the typical presentation, the majority presentation, also called classical presentation of disease. That's what we want to let us understand. So what we have got here, the effect majority, it is the presentation of the disease. But make it red, change the color to red and write down that DIP involvement. Write the point here, the different point, DIP involvement. DIP is distal interphalangeal joint. DIP is distal interphalangeal joint is rare and late in the disease. We want to know that distal interphalangeal joint involvement is rare or late in the disease. Okay, this is the second slide we are doing. So early DIP involvement favors the diagnosis of psoriatic arthropathy. So I am making you write down the differences. So we have written down most common pattern of involvement in RA. But if the patient of arthritis comes with distal interphalangeal joint involvement early in the disease, you must suspect the patient might be having psoriatic arthropathy, may be suffering from psoriatic arthropathy rather than RA. Okay, that's what we want to know. So look at the one here. So extraocular. So we make a proper full table in the page and we will continue this table over to the next page also. But on this side, we will complete some extra-articular features. Extra-articular features. So extra-articular feature from top to bottom, we want to enumerate. From head to toe, we will enumerate the extra-articular features of the disease. So one feature affecting the eyes. Yes, ocular involvement can occur in the form of episcleritis, redness and foreign body sensation. Episcleritis can occur in the eye. An important point to note here, again, important point to note here, uveitis is a feature of SPA. Please remember, uveitis cannot occur in RA. Please remember, uveitis is a feature of SPA. In RA, it can be episcleritis, it can be sicca. We have written one of the secondary causes of Sicca syndrome is RA. So patient of RA can get episcleritis, can have symptoms of Sicca, but never uveitis. Because if the question is asking you uveitis, it is a feature of SPA. Uveitis is a feature of SPA, right? That's what we must underline. Lung involvement can occur. Lung involvement can occur. Lung involvement more common in the males. So remember, RA is common in female. RA is common in female, but the lung involvement is more common in the males. Lung involvement is more common in the male. And most common type of ILD, most common type of interstitial lung disease is UIP. What is this UIP? Usual interstitial pneumonia. Please note it down. Most common type of interstitial lung disease in RA is the UIP. UIP full form is usual interstitial pneumonia. And why it is important to remember? Important to remember because all other autoimmune disease. Important to remember because all other autoimmune disease, the most common type of ILD is NSIP. Most common type of ILD is NSIP. NSIP we have written when we discuss the topic systemic sclerosis and Sicca syndrome. We have written non-specific interstitial pneumonia. So autoimmune disease, most common type of ILD is the NSIP. RA is an exception. That's why we are highlighting. RA is an exception to the rule. So RA presents with UIP, usual interstitial pneumonia, right? Let us take it forward, continue the table. So continue this table. In the articular manifestation, okay, continue the table on furthermore. Articular side, what we have written is the most common pattern is appendicular dominant, and other side, axial involvement is rare. So RA majority cases are appendicular dominant. That means spine involvement is rare. Spine involvement is extremely rare. So if affected, what can happen? So continue writing with me. With the arthritis, most common we have written. Continue further. Axial involvement is rare. But if it is affected, most common site is atlantoaxial joint. Most common site is atlantoaxial joint, and that too high cervical. Atlantoaxial is the first joint, and if it extends further, it will affect the high cervical joint. It will affect the high cervical joint. And why is it important? Again, why is it important? Because low cervical spine involvement is a feature of ankylosing spondylitis. Low cervical spine involvement is a feature of ankylosing spondylitis. So again and again, I am trying to tell you, if you recall yesterday's approach table that we made, we discussed that inflammatory pauciarthritis is likely to be crystal induced after excluding trauma. Same way, inflammatory polyarthritis can be most commonly rheumatoid arthritis, but the differential diagnosis is one of the SPA, spondyloarthropathy. That's why wherever necessary, we are highlighting the differences between RA and SPA. So low cervical is affected, then we are going to think of ankylosing spondylosis rather than the RA. On the other side, continue extra-articular feature. Continue extra-articular features. We can continue. Extra-articular feature, cardiac involvement. Cardiac involvement, most common valve defect. Most common valve defect is MR, mitral regurgitation. Most common valve defect is mitral regurgitation. Most common is mitral regurgitation, because in rheumatoid arthritis the mitral leaflets are destroyed. The mitral leaflets are destroyed, leading to the problem. So musculoskeletal, second problem. So we have written in the extra-articular, we have started with ocular, we have written lung involvement, we have written cardiac involvement. There can be also musculoskeletal involvement. There can be musculoskeletal involvement can occur. What is the feature in musculoskeletal involvement? Musculoskeletal patient can present with myopathy with osteopenia. Patient can present with myopathy with osteopenia. Patient can have myopathy with osteopenia can occur. And because of this musculoskeletal problem, there can be early degeneration of the joint. There can be early degeneration of the joint, and because of that there can be early onset of OA. There can be early onset of osteoarthritis. So yesterday I told you that what we are understanding here, that you asked me yesterday that can degenerative and inflammatory arthritis occur together. This case is most important in the understanding. Please remember, the average age group of a RA patient is a young to middle aged female. So let us say a patient is diagnosed with rheumatoid arthritis at 25 years of her age. After that, she started on the medication. She feels better and the disease is controlled. But when she becomes 40, she starts experiencing worsening of the symptom. Now, most doctors will make a erroneous diagnosis that the RA has become uncontrolled. Please remember, after 40, it is not RA. It is likely that she has now developed osteoarthritis. So RA was the beginning problem, which was controlled with medicine. But because of the musculoskeletal involvement, there was early degeneration of the joint. And now the patient has developed symptoms of osteoarthritis. This is important to us. This is going to be osteoarthritis can occur. Myopathy means muscle weakness. That's all. That is because of the extra articular manifestation of the disease. So this is very important for us to know. So up to a decade earlier. So what can happen? This can happen. It can happen 10 years before. So decade earlier. Yesterday we discussed degenerative arthritis you expect after 50 years of age. But in a patient of RA, you must suspect osteoarthritis after 40 years of age. Okay, please remember this. This is a clinically important point. So osteoarthritis can occur early in a patient of rheumatoid arthritis. It can occur, right? So this is what is the problem here. So there can be Feltis syndrome, famous one, extra articular. Continue on that column. Column is extra articular. So we are enumerating one by one extra articular symptom. Have you written it till here? And I am revising with you. Extra articular symptom. Ocular involvement can be in the form of episcleritis or Sicca syndrome. Lung involvement is more common in males, and the common type of ILD is UIP. Whether other autoimmune disease, common type is NSIP. In cardiac involvement, pericarditis can occur. Yes, it can occur, but it is rare. It is commonly what can happen, the commonest valve. Does not mean MR is most common. Pericarditis is most common cardiac involvement. But valvular involvement, most common is chronic mitral regurgitation can occur in the patient. Along with that, there can be musculoskeletal system. Musculoskeletal system can happen, which can affect early osteoarthritis can occur. And beyond that, we are dealing with Feltis syndrome. Decade earlier it can occur. Osteoarthritis can occur 10 years before the normal population. That means normal population you expect it at 50, but in RA it can come at 40 years of age. Come to Feltis syndrome. So Feltis syndrome is basically what? Common points, MCQ, short answer question and practical viva. This is a question that is asked. Yes, you can write pericarditis also can occur, but it is not asked in the exam ever. That's why I am writing what is relevant to know. Pericarditis can also occur in the patient of RA. True statement. So coming back, what is Feltis syndrome? Feltis syndrome is RA plus splenomegaly. Feltis syndrome is RA plus splenomegaly, which indicates hematological involvement in RA. It indicates hematological involvement in RA. Yes, hematological is extra-articular manifestation. It is one of the extra-articular manifestation. Yes, continue with the differences. So we have got extra-articular manifestation, hematological, but important. Smear shows anemia and neutropenia. The smear, complete blood count when you do in a Feltis syndrome, you will see, yes, continue in the different section. Smear shows, you can write the notes the way you want to organize it. Okay, I am going to post my notes for you on Facebook at the end of the class, right? But it is part of extra articular only. Okay, so smear shows anemia and neutropenia. Why it is important? Why Feltis syndrome is important? Because it is a precursor of lymphoma. Because it is a precursor of lymphoma. Precursor of lymphoma, right? Hence was considered a dreaded complication of RA. Hence was considered a dreaded complication of RA, right? So what is happening? Feltis syndrome. Feltis syndrome was considered dangerous because it can lead to lymphoma, which can lead to death of the patient. Which can lead to death of the patient. So what happens here? But presently, the good news now. So it was considered dangerous, but the good news now, presently, hematological involvement is the least common organ involved. Present concept, hematological involvement is the least common organ involved. Least common organ involved. MCQ point, least common organ involvement in RA is hematological. And what is the incidence? The incidence is now less than 1% of advanced RA only. So the present incidence, previously lymphoma used to be common and used to cause death. But now it has become least common and it occurs in less than 1% of advanced RA patient only. It occurs in less than 1% of advanced RA patient only. And why it has become possible? It has become possible due to early DMARD use. It has become possible due to early DMARD use. That's how it is important. Become possible due to early DMARD use. It has become possible. So what is important to note? I want you to note these points here. The steroids, please remember, steroids offer only symptom relief in RA. Last session we have discussed lupus group of disease. In lupus group of disease, if you remember, we said the drug of choice is steroid. First line of treatment is steroid, but not in RA. We are writing the reason why not steroid. We are writing the reason why not steroid in a patient of RA. Because in RA, steroids offer only symptom relief. Steroids offer only the symptom relief and hence it is palliative only. Hence it is palliative only. Okay, so DMARD, what is the full form of DMARD? Disease modifying anti-rheumatoid drugs. Disease modifying anti-rheumatoid drugs. Disease modifying. Yes, Revin Selvan, thank you. So disease modifying anti-rheumatoid drug. So here steroids don't prevent. We want to write steroids don't prevent joint deformity or systemic complication. The steroids don't prevent joint deformity or systemic complications. They don't prevent. And that is why in RA, the first line of treatment is DMARDs, not steroid. Please remember, we are comparing every disease in rheumatology in a way, trying to highlight how it is different from the others. In lupus disease, the first line treatment is steroid. But in RA, the first line treatment is DMARD because steroids offer only symptom relief to the patient. It offers only symptom relief to the patient. This is the extra points that I wanted you to know. Continue further. Right. So, hence, first line of treatment in RA is DMARD. First line is DMARD. And when to start? There was a question. When to start the DMARD? It should be started on day 1. It should be started on day 1 of the diagnosis. It should be started on day 1 of the diagnosis. Please remember, if you read Remember Pharmacology, the examples of DMARDs are methotrexate, hydroxychloroquine. These are examples of DMARDs. So, in which is covered in pharmacology class. So, DMARDs we have written when we wrote SLE. They are also examples of steroid sparing agent. So the onset of action takes 6 to 8 weeks. Onset of action takes 6 to 8 weeks. That is why we have to start DMARD on the day of diagnosis. Once you confirm that the problem is RA, immediately start the patient on DMARD. So what does DMARD do? It not only prevents the progression of joint involvement, it also prevents systemic complication. It also prevents extra articular manifestation. That's what we want to know. Continue further. So what are the stages of RA? Let us write down. Let us make an illustration. What are the stages of RA? Let us make the illustration, right? So what we have got here, so we have written down clinical manifestations of RA. We have written down. We have written the articular features. We have written extra articular features system wise. Now we have to know the stages of RA. Stages of RA. I always say to understand the pathology, first you must start with anatomy. I want you to type what are the normal components of a joint. So let us look at this. Normal components of a joint. You can draw this picture after I show you. Don't worry. I will post it on the club also. So what we have got? Normal structures of the joint. Normal articular structures. Normal articular structures are the synovial membrane. This is the joint we want to draw. Joint, appendicular joint. The first one is synovial membrane. There is cartilage end plate. Yes, clinical features are over. Clinical features are over. Now you switch to stages of RA. Clinical features are over. Switch to stages of RA. There is cartilage end plate. Cartilage end plate. There can be cartilage end plate at the bone end of the joint. There is the cartilage end plate where my laser is, pointer is. This is the cartilage end plate and there is the bone itself. So together synovial membrane, cartilage end plate and the bone together are called as normal articular structures. So all of you, now you will remember what is synovitis. Synovitis is the first stage of arthritis. When inflammation has begun in the synovial membrane, then you call it as synovitis. But it is a subtype of arthritis only. So joint involvement, any one of these three structure is affected, that means what it is there? Arthritis is present. Any one of these structures are involved, inflamed, that means arthritis is present. Right? Arthritis is present. So connect the two. So what we have got? The whole joint. So what I want you to draw with me? I want you to first draw a normal illustration. Make a joint, then draw a line in the middle. Make a joint and then draw line in the middle. So average joint, it consists of the bone on both sides. There is the cartilage end plate on the ends of the bone, and the bones are covered by the synovial membrane. Bones are covered by the synovial membrane. So compare that to stages of RA. Stages of RA, the primary stage or the first stage of RA. Primary or the first stage of RA is the synovitis. The first stage of RA is the synovitis. So first inflammation begins in the synovial membrane. So recall SLE topic we discussed. In SLE also most common feature is synovitis. That's why I told you in the initial few days the joint involvement of SLE and RA can look similar. But especially if you do the X-ray, the erosion, if it is present, favors diagnosis RA. But when erosions are absent, it favors a diagnosis of the lupus group of disease. That's how I want you to compare between the two. Compare between the two. So first the disease starts with synovitis. If you do not treat the patient, patient develops pannus formation. That is, the cartilage end plate becomes involved. There is erosion of the cartilage end plate in blue. There is erosion of the cartilage end plate in the blue. And finally, if you don't treat the patient develops bone erosion in purple. Patient develops bone erosion in the purple. And these bone erosions are the one which are responsible for causing irreversible joint deformity. Bone erosions are the one which are important for causing irreversible joint deformity. Irreversible joint deformity can occur. So please compare in SLE, since only part of the joint affected is synovial membrane, the bone is not affected. Since the bone is not affected, that is why it does not cause irreversible deformity. If you remember, we had discussed the topic Jacob's arthropathy under SLE. We have discussed the topic Jacob's arthropathy under SLE. What is it? Non-erosive arthritis. Here there is erosive arthritis. Pannus formation means erosion of the cartilage end plate. You are comparing the two sides. Pannus formation means erosion of cartilage end plate can occur. Pannus formation is the erosion of cartilage end plate. And finally, we have got bone erosion, which leads to irreversible joint deformity. Leads to the irreversible joint deformity. Okay, so keep our proforma. That's why first day I told you, focus first on the proforma. Every disease that we are learning RA is the most common cause of inflammatory polyarthritis, which affects young to middle-aged female. Family history is not common. Majority patient present with articular symptom, but extra-articular symptom can also be present. When you look at the stages of RA, first it begins with the synovitis. Then there is erosion of cartilage end plate. then there is erosion of the bone, which will eventually lead to joint deformity. So we want to know what are the common two deformities associated with RA. Which are the two deformities associated with RA? We want to understand the deformity associated with the RA. So let us look at the number one, swan neck deformity. We are looking at the swan neck deformity. So swan neck deformity, everybody don't look at the swan neck here, look at the hand picture also. So distal there is going to be the flexion at the DIP, hyperextension at the PIP joint. So the two common small joint deformity are one, that is the swan neck deformity. There is the swan neck deformity. Swan neck deformity is there, and other one is the bottinier's deformity. Okay, so botinier, actually botinier does not mean the sword or the bayonet, but typically this is how you remember. This is how you remember bottinier's deformity. You know, when we are old time, that rifle used to be there, no? Rifle has got a blade in front. The old rifles which are kept in the museum have got this rifle. I'm sure you have all watched Kesari movie. So we have got these old time guns which have got a bayonet like this. So how the appearance is? This is like the gun and you have a protrusion. You have got a knife like a bayonet. It is there. These are our two typical deformity. These are our two typical deformity that we have. So two common small joint deformities in RA can occur, but these points occur when they occur only when there is bone erosion. They occur only when there is bone erosion. That's what we want to know. Continue further. So what is the clinical test for RA? Come on everybody. What is the clinical test for RA? Clinical test for RA. So yesterday one of the student had put up this doubt. What is the clinical? So patient comes with joint pain and swelling, typically affecting small joint of the hands. What is the clinical test for RA? Clinical test for RA. Look at this. It is the squeeze test. Look carefully. It is the squeeze test, which is the clinical test for RA. Look at this carefully, the image. Okay, so if the MCP squeeze test, we have got the MCP squeeze test, and there is the MTP squeeze test. So metacarpophalangeal joint, metatarsophalangeal joint. So what we do typically, we shake hand with the patient. You shake hand with the patient and you squeeze the MCP rather. MCP squeeze test is what we want to do. So squeeze test is one of the most reliable tests for rheumatoid arthritis. But it can also be positive in psoriatic arthropathy. Please remember, because it depends upon the pattern, not on the disease. If the joints of the MCP are involved, then the test will be positive. Psoriasis can also affect the MCP joints, and that is why it is one of the reliable test for rheumatoid arthritis. So what did you do? Involve squeezing the hand or the foot across the knuckle joints as it is shown. So this is the common test. And if the test is unduly painful, it can indicate one of the above conditions, right? So we are looking at the one of the conditions. Okay, so what we are doing, clinical test for RA. Okay, I will show you, I will put up the deformities again in the slide. It is there in your image section, so don't hurry, you will be able to get that right. Okay, so let us come to see. So painful, it is unduly painful, can be test considered as positive. Test is considered as positive. So let us look at this again. Please, I am keeping on revising for you so that you can visualize the patient in front of you. Think of a 25-year-old lady who has come to you with joint pain, especially small joints of the hand. The feature I described yesterday, what does she complain? That when she gets up in the morning, she is unable to even fold the finger. She is having severe morning stiffness lasting more than 30-minute duration. That is the typical presentation. Wrist can be the starting point, MCP can be affected, PIP can be affected. More because the joint involvement is so severe, she may not report the extra-articular problem initially. So what you do, you will first do the squeeze test to see whether the joint is inflamed or not. If it is positive, then you continue for further evaluation. As I told you, first step in rheumatology is what? Clinical suspicion. First step, I have come thinking clinically, thinking whether the patient has got RA. I am thinking whether the patient has got RA. So how to make the diagnosis? How to make the diagnosis of RA? Let's write down. So we have got the Euler ACR score. So we have got the, okay, right. So let us see, the Euler ACR score can be used for diagnosis of the disease. Can be there for diagnosis of the disease, right? So diagnosis. So first question is, I'm noting your doubts. Please continue with the class. I'm noting your doubts, okay, and I will answer them for you. So write with me the diagnosis. When do you want to perform Euler score? When do you want to perform the Euler score? So you must perform the Euler score in all patients with inflammatory arthritis. You must perform Euler score in all patients with inflammatory arthritis without history of trauma. All the patients of inflammatory arthritis without history of trauma must undergo Euler score. Euler, I have already told you, Euler full form is European League Against Rheumatism. European League Against Rheumatism. And ACR, ACR means American College of Rheumatology. ACR means American College of Rheumatology, right? So how do we proceed? So Euler, it is the European League Against Rheumatism. It is the European League Against Rheumatism. So we want to perform Euler score in all patients. Again, please remember, commonest cause of inflammatory polyarthritis is RA. That is why when patient has inflammatory arthritis, you will start by performing Euler score. So what is the summary? Euler score, 4 parameters are used in the scoring. In the Euler score, 4 parameters are used in the scoring along with the maximum score. 4 parameters are used in the scoring along with the corresponding maximum score. Okay, so write it down please. Make this simple table. First parameter, I told you yesterday only, most important parameter in reaching the diagnosis is the pattern of joint involvement. Most important parameter to reach the diagnosis in a case of arthritis is to look at the pattern of joint involvement. So based on the pattern, the patient can get a maximum score of 5. Based on the pattern of joint involvement, patient can get a maximum score of 5 points. Maximum score of 5 points can be there. Along with the pattern, what is there in rheumatology? We know antibody testing. That is why we already studied these antibodies. We can take the help of antibody testing. Both RA factor and anti-CCP. Both the anti-RA factor and anti-CCP. Please recall from yesterday's class. Rheumatoid factor is sensitive and prognostic. Anti-CCP is specific and prognostic. It is specific and prognostic we want to learn. So serology, both RA factor and anti-CCP are taken into consideration. Yesterday you had given me a doubt, okay? What happens if RA factor is positive anti-CCP is negative. In that case, RA factor is likely to be false positive. You have to see that consideration and look at other parameters that I am teaching you today. So if RA factor is only positive, anti-CCP is negative, in such patient, RA factor is likely to be false positive. That means it can be a feature of some other disease, not of RA. But we must consider other parameters that I am teaching you today. Right? So we also want to take into consideration the duration of arthritis. We want to take into consideration the duration of arthritis. That is 1. Duration of arthritis can be given 1 point, maximum score of 1 point. And finally, you look at the objective markers of inflammation. Please recall, yesterday when we wrote notes for morning stiffness, we have written objective markers of inflammation. ESR and CRP must be done. ESR and CRP can be done, and that will give a point of 1 point. You will get it as 1 point. So based on the serology, based on all these 4 parameters, okay, you will give a score to every patient with inflammatory arthritis. So the maximum score possible is 10. Maximum score possible is 10. And if the score is more than equal to 6, it is confirmatory of RA. When the score is more than equal to 6, it is confirmatory of RA. When it is more than equal to 6, it is confirmatory of RA. Right? So this is our simple method to diagnose. So again, as we go along, we will integrate more points. So that day when I was teaching you SLE and I told you the updated criteria. What is important? Updated criteria is of SLE. Please remember everybody, updated criteria of SLE is now a scoring system like this one. The previous score, what we studied in SLE, please remember, SLIC criteria. SLIC criteria was criteria. You have to count number of manifestation present. But the updated version is a score. You have to give point for each manifestation. You have to give points and count the total. So in the new updated criteria of SLE, score more than equal to 10 confirms SLE. Like that, in RA today we are learning that Euler score more than equal to 6 is confirmatory. Euler score more than equal to 6 is confirmatory is what we are learning today. So Euler score gives us the diagnosis for RA. Okay. So please remember, whatever I have just shown you is enough for you to remember. What I am going to show you now is only for your understanding. Please don't write, just listen and follow the laser pointer. Okay. What I am going to show you today is the breakup of this score. This is only for your understanding. This is only for your understanding. How to score, it is for your understanding. Do not write, listen. It is available on Google, hundreds of images. Just read with me. Okay. Number 1, please read with me. Everybody is asking same question. I am going to teach that, but just read with me. So what we will do, based on the joint involvement, you will see what is happening in your patient. So if only one large joint is involved, you will give 0 point. So in a patient with arthritis, if only one large joint is involved, then you will do only 0 point. They will do 0 point. If 2 to 10 large joints are involved, you will give 1 point, because it is still unlikely to be RA. No? RA is typically small joint polyarthritis. So we have to see that what to do. So as I said, this is not to be written. I am telling 100 times. This is for you to understand. So that too, if you are interested, okay, this is for us to understand. I'll post this. 1 to 3 small joints are there, 2 points. 4 to 10 small joints are there, 3 points. And more than 10 joints are involved, then you get a maximum score of 5. Then you get a maximum score of 5. This is what you are getting it. That is what you are getting, maximum score of 5 based on pattern of joint involvement. This is only for your understanding, not for writing. We only are expected in the exam, they can ask you what are the parameters used for diagnosis. They will not ask you to calculate the score. Okay, they will ask you what parameter. One of the parameter is the pattern of joint involvement. Number two, serology. Number two, serology. At least one test. So you will see negative RA factor, negative ACPA. Answer score is 0. If both are negative, score is 0. If you have low positive RA factor or low positive ACPA, you will give 2 points. If you have high positive, then you will get maximum of 3 points. Maximum of the 3 points. So that is how you can calculate maximum score of 3. Acute phase reactant. Again, read the point here. I am clarifying. Only one test is required. Both RA and ACPA not required. Only any one is okay to give the score. Similarly, acute phase reactant. At least one test is required. If ESR, CRP are normal, that means 0 points. But if they are elevated, you will give 1 point. 0, if it is positive, you will get 1 point. You will get 1 point. Okay, that we will give. And basically duration of the symptom. Less than 6 weeks, 0 point. More than 6 weeks, 1 point. So the maximum score the patient can have is 10. Maximum score the patient can have is 10. 5 plus 3 plus 1 plus 1. Maximum score can be 10 points using the small joint involved, using the Euler score. If the score is more than equal to 6, the diagnosis of RA is confirmed. If the score is more than equal to 6, the diagnosis of RA is confirmed. Let us take it forward. But what is the big point here? No radiology for diagnosis. What is the no radiology for diagnosis? No radiology for diagnosis. So this is an important point. I want you to note in your writes that in the new Euler score, there is no place for radiology. So even though radiology is an important investigation in arthritis patient, it is no longer recommended for the treatment. I am going to enumerate the reason for that. We are going to write down the reason for that. There is no radiology for diagnosis. We are going to write down the reason for that. Number one question, everybody answer please. Number one question, answer please. Earliest radiological feature. Earliest radiological feature. Earliest radiological feature. I want the answer. What is the earliest radiological feature? In patient of RA, which is earliest radiological feature? I want you to answer. Very good. Very good. So earliest radiological feature is the peri-articular, that is also called as juxta-articular osteopenia. Very good. Yes, you have to write this. You have to write this. The earliest manifestation, very good, is the juxta-articular osteopenia. It is the juxta-articular osteopenia. Synovitis cannot be seen on X-ray. Synovitis cannot be seen on X-ray. The earliest radiological feature that can be seen is the peri-articular osteopenia. Peri-articular osteopenia. But why not then include it in the diagnosis? If it is an early feature, why not include it for diagnosis? We don't include it for diagnosis because it is sensitive but non-specific. So we are writing the reason why we are not using radiology for diagnosis of RA. That's what we are taking down. So it is not included because it is sensitive but non-specific, right? Next one, routine radiological test. What do you do routinely? You do MRI? No, we do X-ray. X-ray is commonly available, but it is not sensitive to detect the erosion. Best test to detect the erosion is MRI, but it is expensive with limited ability. So you cannot do it in routine patient. So moral of the story, whichever way we look at this, radiology as a part of diagnosis does not fit in RA anymore, because what is early in RA is non-specific, and what is specific, what is specific erosion, that is difficult to detect on routine examination. That is why radiology is not included. Radiology is not included in the diagnosis of RA. This is what we want to know. Not included. Osteopenia means loss of the bone density. Loss of the bone density. The area of the bone around the joint appears thinned out, appears translucent. Okay. Osteopenia means reduced density. Around the joint, the bone starts looking translucent. That is the earliest feature of the disease. Let's come to the other one, treatment. So again, so what are we done? Diagnosis is complete now. Everybody with me. Come on, we are together. When young female comes with the articular symptoms, morning stiffness involving small joint, you will perform squeeze test. Squeeze test is positive, clinically suspect RA. For diagnosis, you will perform Euler score. Please remember, radiology not for diagnosis. Euler score more than equal to 6 confirms the diagnosis. After diagnosis, come to the treatment. But treatment depends on the severity. The treatment depends on the severity. Depends on the severity. Depends on the severity. So this is a common picture that you will see in the rheumatology clinic. This is called as a homunculus diagram. Homunculus diagram. This is seen. Homunculus diagram. You will see this picture in the rheumatology clinic. So whichever joint is affected, they will take a red pen and mark it. They will put a red pen and mark it. So we have got here homunculus. So there are all the joints are marked here. So depending on which joint is affected, rheumatologist will shade that area so that we can understand it better. But what we want to do? We want to do clinical disease activity index. The treatment depends on the severity. The treatment depends on the severity. Please remember, Euler score only confirms diagnosis, does not tell you how bad the disease is. It tells you only the diagnosis, does not tell you what is the severity. Most preferred for severity is the clinical disease activity index. Most preferred score for severity. Most preferred score for the severity is the clinical disease activity index. How do you calculate disease activity index? Note it down quickly. How do you see disease activity index? Very simple. Number 1, count the number of swollen joint. How will you calculate? Number 1, count the number of swollen joint, SJ28. Number 2, count the number of tender joints. Count the number of tender joints. Two things you have to do. For each joint which is swollen, you will give 1 point. For each joint which is tender, you will give 1 point. So you have to count basically 28 joints. If they are swollen, 1 point. Tender, 1 point each as per their affection. So which are the 28? Which are the 28 joints that we want to know? Write it down. Which are the 28 joints involved? We want to write down. Yes, yes. At that time, SJ swollen joint. SJ means swollen joint. TJ means tender joint. On a tender joint, swollen joint. 28 joint गिनना है. 28 joint you want to count. Which are the 28 I am giving in front of you? So there are 10 MCP joints, metacarpophalangeal, 10 MCP both hands, 10 PIP joints and 2 wrist. So already 22 हो गया. Along with that you count the 2 elbow, the 2 shoulder and the 2 knee. So you have to check that out of these 28 joints, if any one is swollen, 1 point each. Any one is tender, 1 point each will be given in the score. Will be given in the score. So this is the 2 important steps you have to do. You will also take into account patient global activity score. You will take the global activity score. Okay. You have to count only these 28 points. You have to count only these 28 joints. PIP, proximal interphalangeal joint. We have to look at the patient global activity 0 to 10. 0 to 10. We have to look for 0 to 10. So global activity means what? This is patient's own score. Patient will think that how bad the disease is according to him or her. Because please remember that disease is there, but patient suffering depends on his occupation also. Suppose an elderly patient has got a joint pain, it may not cause much effect in quality of life. But a young student gets joint pain, it can affect quality of life. So this is called patient global activity score. It is part of the CDAI. I am writing in the same page. Part of the CDAI. You will give 0 to 10 point. 0 to 10 point. And you will also give doctor, that is evaluators, global activity score. Global activity score 0 to 10. Global activity score also gets 0 to 10. 0 being mild, 10 being most severe. So you have to count. So patient can get 28 points for swollen, 28 for tender, 10 for patient activity, 10 for doctor. So patient is having, this is the rheumatology homunculus. Okay, not important. Focus on the points that are there. We want to look. So please remember, why not lower limb? That is the shortcoming of this test. But this is the defined test. मैंने नहीं बनाया रे. CDI मैंने नहीं बनाया. So ऐसा question मुझे मत पूछो, है ना? Difficult. This is the fallacy of the test. This is a fallacy, but commonly RA affects hand joints. That is why the leg joints are removed from this test. That is how they decided. It's a shortcut basically. That is what we want to look. So we want to count. We will count them only when they are actively involved. We will count the joints which are actively, that means simultaneously involved. That's how we have to do that. Right? So that's what we want to look at this. So based on that, how do you interpret this? How do you interpret? How do you interpret the CDAI score? How do you interpret the CDAI score? So I told you, basically, this is what? This is what the score for severity of disease. Euler score gave you diagnosis of RA based on the CDI. Now we will say, if the CDAI score becomes less than equal to 2.8, फिर से सब पूछेंगे डेसिमल क्यों है? अरे वो स्टैटिस्टिशियन का काम है. Statistically, this is the significance of the score. Okay, decimal में आएगा ऐसा नहीं है, but this is the interpretation given to you. You have to take it or leave it. This is the answer we have to understand. So if the score is less than 2.8, less than 2.8, yes, this is important for exam. Less than 2.8, we will say patient is in remission. This score is important for exam because it is given in the question and you have to plan the treatment of the patient according to the score. So this is important in the exam. Low dose disease activity, when the score is between 2.8 to 10, we call it low severity. We call it low severity. Moderate disease activity 10 to 22. Moderate disease activity 10 to 22. And high disease activity more than 22. High disease activity more than 22. This is what we want to remember. So we want to know what are the scores, what are the severity indices, and the most preferred we have learned is the CDAI, Clinical Disease Activity Score. Anna? So please understand here that how will evaluator give the score? You have to look at the patient. Patient may have the RA before, some joints must have got destroyed. Patient is immobilized, that means severity is more. Okay, so patient, depending on his quality of life, in his independent lifestyle, over all these things you will give a score. It is a subjective score, उसके लिए guideline नहीं है. It is your perception. What you feel, like that you have to give. What you feel, you have to give. Right? So the joints which are swollen, tender, at that time of assessment, you have to count. At the time of assessment, you have to count. So what is the treatment algorithm? Please write down. Treatment algorithm. Okay. So treatment algorithm, इसको लिखते हैं. Let us make the chart. What is the treatment algorithm? Okay. So make the chart with me, please. Make the chart with me. You have to start the DMARD as per the CDAI score. What is the principle I'm writing for you? Principle is there that start the DMARD as per the CDAI score and then reassess after 6 weeks. So because I told you minimum time for onset of action is 6 weeks. So if you give methotrexate, you have to give 6 weeks for the improvement to occur. And how do you know how much is the improvement? How do you know what is the improvement? Improvement if RA goes into remission, or improvement in score should be more than 6.5. Means it must become less. The score must become less by more than 6.5 score. That means the medicine is working. That means the medicine is working and you will continue same treatment. Then you will continue same treatment. Okay, max score का जरूरत नहीं है. CDI 28 plus 28 plus 10 plus 10 मैथमेटिक्स करो घर पे बैठ के, है ना. But that's not important. What is important? Score कितना. Depending on the score, you categorize the patient of RA into mild, moderate and severe. After categorizing, you start the patient on treatment. After starting a particular treatment, you wait for 6 weeks for the result to occur. After 6 weeks, you have to again check the CDI score. If the CDI score has improved by more than 6.5, that means medicine is working and you continue same treatment. Now you continue same treatment. That's what you want to do. Now, what is the things? So mild, moderate and severe RA. Make the table. Make the table. Mild, moderate and severe RA. How should you start? How should you start? Mild, moderate, severe RA. How should you start treatment? Come on. How should you start treatment? Come on everybody. It's very important. It's a protocol we want to know. So in the exam, how will the question come? In the exam, patient with a case of RA having EULAR score of 7, that means RA is confirmed, with a CDAI of 6, that means mild RA, what treatment should be given? So score will be given to you and you have to plan the treatment, like in live medicine, like in clinical medicine, you have to plan the treatment. So what do you do? Low dose methotrexate, drug of the choice. Drug of choice is methotrexate. First point is to look at the methotrexate. So in a patient with mild RA, you will first start on low dose methotrexate. Same principle. Wait for 6 weeks, assess. If improvement is good, continue same dose. But improvement is not there. Improvement is not there. Very good. Single drug. In mild RA, you will start with single drug. And the single drug is low dose methotrexate. If the improvement is there, you continue same agent. Continue same agent. But improvement is not there, you will switch to high dose methotrexate. But if the improvement is not there, you will switch to high dose methotrexate. Improvement is not there, you have to start on high dose methotrexate. If with high dose methotrexate also the disease is not controlled, then you add second DMARD. Then you add the second DMARD. Then you add second DMARD. Second DMARD क्या क्या हो सकता है? हाइड्रोक्सी क्लोरोक्वीन HCQ, सास सल्फासेलिजीन, सल्फासेलिजीन, सास सल्फासेलिजीन, और लेफ्लुनामाइड. So if the high dose methotrexate does not give us relief, you will add the second DMARD. The choice of second DMARDs are hydroxychloroquine, sulfasalazine and leflunomide. Sulfasalazine and leflunomide, right? So if not improved, you will add the third DMARD. You can do a classification. Add the third DMARD. You will add the third DMARD. And if that also doesn't work, you have to consider newer agents in RA. Consider newer agents in RA. So first we have to classify. After confirming diagnosis of RA based on the CDAI score, you will classify the patients of RA into mild, moderate and severe. If the patient has mild RA, you will start patient on single DMARD, that is methotrexate. First start with low dose. Does not work in 6 weeks, make it high dose. Does not work in 6 weeks, add second DMARD. Does not work in 6 weeks, add the third DMARD. And if that also does not work, then you consider newer agents in RA. Then you consider the newer agents in RA we want to do, right? On the other side, so dual DMARD therapy, if it is moderate RA, if it is a moderate RA, you will start the patient on dual DMARD therapy directly. Patient is having the more RA severity, you will start on combination DMARD directly. Again, wait for 6 weeks. If it doesn't work in 6 weeks, then you add third DMARD. Okay? Then you add the third DMARD and consider newer agent if it is not responsive. Add the third DMARD. If it is not responsive, then consider newer agent in RA. In severe RA, we directly start with triple DMARD therapy. Okay, in severe RA, start with the triple DMARD therapy. And if only wait for 6 weeks. If it does not give improvement, you will consider newer agents in RA. You will wait for 6 weeks. And if it does not work, you will consider newer agents in RA. This is how we have to approach. Okay. Third DMARD example nahi Anudeep, है ना? All these are DMARDs, no? Methotrexate, hydroxychloroquine, sulfasalazine, leflunomide. Usme se we will take up the patient. We will take up the any three combination. Okay. So Mohit Dashore, you are asking how to know mild, moderate, severe. When I have told it 100 times based on the CDAI score. Third DMARD is any one of this. You have to choose. These are the 4 commonly prescribed DMARDs. You have to choose any one of this. So first line therapy is to start the patient on DMARD. Everybody, first is to start the patient on DMARD. If the DMARD does not work, then only we want to start the patient on newer therapy. Okay, so please remember, okay, the Bharatiya Mahila is still stuck on the question, what is mild RA less than 6 Mild RA when it is 2.8 to the 10 score already I have given. Okay, read it again. Don't get confused. So this is what you want to continue. So which are the newer agents in RA? We want to know which are the newer agents in RA. So DMARDs are going to be the main treatment. Along with that, for palliative therapy, you can prescribe NSAIDs, you can even prescribe steroids. That is for palliative therapy, that is pain relief. That is for palliative therapy. Yes. See, Harshita, every time we reassess the thing, we have to consider that new score, no? Otherwise, if it was to consider previous score, why we will reassess? Slowly, thoda socho na. We want to use the new score only, and then according to new score, we want to start the next point, right? So that's how the thing should continue, right? Okay. So what are the newer agents we want to discuss here? What are the newer agents we want to discuss here? So the newer agents are divided into 2 groups. Newer agents are divided into 2 groups. Two groups are, one, write in the colors. Green colors are biologicals. Green colors are biological. Green color is biological. They are the MABs, that is the monoclonal antibody. They are the monoclonal antibody. Monoclonal antibody we want to write. And there are the group of immunologicals. Immunologicals are the TNIPs. Immunologicals end with the affix, the TNIPs. They end with the word TNIPs. So every 6 weeks we have to look at that. Every 6 weeks we have to look at that. What is the score? What is the disease activity? According, if the improvement is there, you will continue same treatment. If activity is not controlled, then you will add the next step. You will go to the next step. That is the treatment choice that we have. So which are the biologicals? Biologicals are called as biological because they are monoclonal antibodies derived from live cell culture. Okay, they are the antibodies derived from live cell culture. Okay, derived from live. That is why the word biological, derived from live cell culture. That is why the word biological is there. Biological is there. Immunological. Immunologicals, tyrosine kinase inhibitor. Immunologicals are tyrosine kinase inhibitors. They are also called as small molecule agent. They are also called small molecule agent. Tyrosine kinase inhibitors. They are also called small molecule agent. This we are going to discuss. The topic of DMARD you will discuss in pharmacology. We are in rheumatology. We are going to discuss the newer agent in RA. We are going to discuss the newer agent in RA. So newer agent in RA, what do they have? High success in inducing remission. The newer agents have got high success in inducing remission. The new agents have got high success in inducing remission. So we will ask, then why not start with them only? DMARDs don't have that much success. Newer agents are more successful. Then why not start with newer agent directly? Why not start with the newer agent directly? You don't start because of the high adverse drug reaction. and the high cost. You do not start with the new agent directly. Very good, because one, it is expensive, and also it is high adverse drug reaction. Also because of the high adverse drug reaction. Especially which adverse drug reaction are we worried about? We are worried about the tuberculosis reactivation. We are worried about the tuberculosis reactivation. Okay, so there is tuberculosis reactivation. Please remember, we will read the mechanism of action. Because they all suppress the immune system, all of them increase the risk of tuberculosis reactivation. And in a country like ours, where many of us may be harboring dormant TB bacilli, using these agents can be dangerous. That's why the problem. But let us know the agents, mechanism of action. So along with the pathophysiology of RA, let us understand. Along with the pathophysiology, we are going to understand, right? So make a chart, make on a new page, write down the mechanism of action and which are the newer agents we are going to write. Mechanism of action and the newer agents we are going to write. So start on a new page, pathophysiology. In RA, there are increase in the pro-inflammatory cytokine. Pathology. In RA, there is increase in the pro-inflammatory cytokine. So which are the pro-inflammatory cytokine? Most potent is the TNF alpha. There is also increase in interleukin 1 level, and there is also increase in interleukin 6 level. Right? So we have got in a patient of RA, the TNF alpha level, interleukin 1 and interleukin 6 levels are elevated, which is further activating the immune cascade. So if you want to suppress the inflammation, you can block this cytokine. If you want to suppress the agent, we have to suppress these cytokines. Yes, we have to suppress these cytokines. So which are they? Number one, so we can block the TNF alpha. Most preferred agents are to give anti-TNF alpha agent. Most best are the TNF alpha agents. Yes. So in the TNF alpha agent, we have got etanercept, infliximab, adalimumab, golimumab, and the pegylated form of certolizumab. So we have got etanercept, infliximab, adalimumab, golimumab, and the pegylated form of certolizumab. Okay, so we have got these anti-TNF alpha agents. So in the treatment of RA, we can look at the anti-TNF alpha agents can be used, because by blocking the TNF alpha, they can suppress the inflammation and they can induce remission. Yes, we must write it if you want. If you want, you can write. If you can remember, that's great. So increase in the interleukin 1. Interleukin 1 antagonist can also be given. The agent is anakinra. Interleukin 6 antagonist can be given. We have got tocilizumab and sarilumab. And the sarilumab. Etanercept. Yes, etanercept. There is infliximab, adalimumab, golimumab, certolizumab. There is anakinra, tocilizumab, sarilumab. So these are our first line agents. So typically we first give anti-TNF alpha agent. in cases where DMARD has failed, in cases where DMARD alone cannot control the disease, you want to consider newer agent. Among the newer agent, most preferred is the anti-TNF alpha. Among the newer agent, most preferred is the anti-TNF alpha. We can also give IL-1 antagonist, IL-6 antagonist. Continue the inflammatory cascade. Continue inflammatory cascade. So TNF alpha plus interleukin 1. TNF alpha plus interleukin 1. What do? They stimulate the T cell. TNF alpha plus interleukin 1 stimulate the T cell. Interleukin 6 predominantly stimulates the B cell. Predominantly stimulates the B cells. So the TNF alpha plus interleukin 1 stimulates the T cell predominantly. Interleukin 6 stimulates the B cell predominantly. These also can be blocked now. So for the T cell, we have got a T cell modulator abatacept. T cell modulator abatacept. Okay, so there is T cell modulator abatacept. And B cell modulator, we have got the B cell anti-CD20, which we studied with SLE, rituximab. We have got the rituximab. We have got the rituximab that we have. We have got rituximab approved for the treatment of RA. Please remember, in SLE, we had also written belimumab. But belimumab is not for RA. It is only for SLE. It is not for RA. It is only for the SLE. Okay. So what it is? So JAK, the T cell and the B cell. The T cell and the B cell together, if you do not control the disease, they will activate the group of JAK. They will activate the group of JAK. JAK is the Janus associated kinases. Okay, there is the Janus associated kinases. So these Janus associated kinases. Okay. So Janus associated kinases. Let us go through everybody's. Okay. Eyes are straining. I'm sorry, Hannah. We have to go through this. So we have got here. Okay. So first page. Everybody okay till here? So we have written the first line agents: anti-TNF alpha, interleukin 1 antagonist, interleukin 6 antagonist. Okay. So we have written these points here. Yes. So anti-TNF alpha, there is interleukin 1 antagonist, interleukin 6 antagonist. We have written. So what they do, they can suppress the inflammation. TNF alpha, you can see here, TNF alpha plus interleukin 1 stimulates the T cell. Interleukin 6 stimulates the B cell. Stimulates the B cell. So we can block the T cell and the B cell also. T cell and the B cell also. What do they do? What do they do? The T cell and the B cell together activate the JAK. What is JAK? Janus associated kinases. Janus associated kinases. Janus associated kinases are there. Janus associated kinases. What are they? Intracellular signaling pathways mediating the inflammatory response. They are the intracellular signaling pathways mediating inflammatory response. This is what we can see. JAK is not given. JAK is the problem. What is there in red is the pathology. Agents are in green. Okay, agents are in green here. So what is next? Let us see here. So what is there? We have got tofacitinib. We have got tofacitinib here. So we have got tofacitinib, tyrosine kinase inhibitor of the JAK1 and the JAK3. So please look carefully. Change in the color. Change in the color is what? The green color agents are biologicals. Green color agents are all biologicals. The purple color are called as immunological. Purple colors are called as immunological. Purple color has called immunological. Okay. Tofacitinib can be given. It is the first oral agent acting on the inflammatory cascade. It is the first oral agent acting on the inflammatory cascade, and it is showing high success in clinical trial. So please remember, in future tofacitinib may replace anti-TNF alpha agent because oral agents are always preferred in practice, but the cost of the therapy remains prohibitive. Cost of the therapy is very high. Hence these agents are not commonly used in clinical practice anymore. Anna, it is available, it's available, but it is used only when other treatment protocols have failed. Used only when other treatment protocols have failed. Okay, so look at the chart together now. Everybody has written down? Yes, baricitinib also is now approved. Okay, I will write it in the chat box later. Baricitinib, Arshdeep Kaur, is also approved for the treatment of RA. So this is our basic slide that we have to do, right? So what we have got here? So basic slide, just look at it from the top. So the first step from pathology, try to recall from pathology. Now read it with me. Once you have written it down, read it with me. Okay, in RA, increased pro-inflammatory cytokine is there. Anti-TNF alpha are preferred. If they don't help, you can try anakinra, anti-interleukin 1. Interleukin 6 antagonist can be tried. Yes, so Urmish Patel, everybody, steroids can be given for the palliative. Yes, acute means what? Presentation is acute only. So that time, if you want, first give NSAID. Otherwise, give steroid temporarily. Okay, steroids don't control disease. Unlike SLE, I have already explained that. Okay, that's what we want to see. And then we have got the T cell modulator, anti-B cell, and the new drug tofacitinib should we have. Okay, many people asking, should we do anti-CCP if RA factor is negative? Answer, that depends on the doctor, and that too brain of the doctor. Please again remember, please grow up. Anna, I want you all to mature as a doctor. Okay, this is not one line questions. You have to look at the clinical scenario. You have to look at the alternative diagnosis. These are not one line questions. Don't oversimplify this approach. It has got to be an integrated approach. You have to look at many factors. It's not just about one two thing, right? So continue further. So prognosis overall has now become favorable. Prognosis has now become favorable because now due to the agents we are able to have early diagnosis. Because of the first line DMARD therapy, we are preventing complication, and newer drugs are available. Though expensive, they are available. So what we have, prognosis is favorable. But what is MCQ wanting to ask? Poor prognostic factor in RA. MCQ wants to ask, what is the poor prognostic factor in RA? Poor prognostic factor in RA, we want to know. Poor prognostic factor in RA. Write it down. Fatafat. Just enumeration I want you to do. Fast. Enumeration only. So female gender, usually severe disease. Advanced stage of onset, more than 40, poor prognosis. Okay. So female gender, advanced stage of onset, poor prognosis. More than 10 joint involvement at diagnosis, extra-articular feature, poor prognosis. Just quickly note down, these are just points, enumerate which are the poor prognostic feature, just the direct points. So female gender, advanced stage of onset, more than 10 joint involvement, extra-articular feature, and high RA factor, high ACPA titer. We discussed yesterday. Both the antibodies are prognostic. Higher the antibody titer, more is the risk of erosion, more is the risk of deformity. That's what we want to know. Gauri Sangle, it is not that disease has gone to jack face. Disease is in jack face only. But it is the order of treatment I am giving. All inflammatory cascade involve jack also. Okay. So that's not the way it is. It's not that concept only you have not got it. So early radiological evidence of erosions. Okay. Gauri Sangle, go through the video again. You have not got the concept. Early radiological evidence of erosion, high acute phase reactants, smoking, poor socioeconomic status, educational level. Okay, so because of lack of awareness, some of you told that our patient follow-up is not there, patients are poor. That is correct, and that is why prognosis is poor. And very correct, Aisha, that the problem is delay in the DMARD, delay in the TREMARD by more than 3 months. Delay in the treatment with DMARD by more than 3 months is a poor prognostic factor. So delay in the treatment is the poor prognostic factor. That's the problem here, right? So these are poor prognostic features, right? So hopefully we completed the topic RA. So yesterday we studied the topic of gout, we studied the topic of pseudo gout. So today we have completed inflammatory polyarthritis. The most common cause of inflammatory polyarthritis is RA. Most common cause of inflammatory polyarthritis is RA. But the differential diagnosis is SPA. That's what is important to complete today. So to complete, we have to go for SPA. So write down here, what is this spondyloarthropathies? Let's write down. What are the spondyloarthropathies? What are the spondyloarthropathies? Let us write it down. Okay, last point of the poor prognosis is the poor socio-economic status and poor education. Okay, that's what is there. Yes. So spondyloarthropathy, that is what we want to complete our arthritis for. This is the complete points. So write down, what are these SPA? So as we know from yesterday's approach, that SPAs are a group of disease. SPA is not one. SPAs are a group of disease having common feature. Please recall from yesterday, which are the SPAs? Ankylosing spondylosis, psoriatic arthropathy, IBD associated arthritis, and reactive arthritis. So SPA has got 4 topics. Ankylosing spondylosis, we have got psoriatic arthropathy, we have got IBD associated arthropathy, and reactive arthropathy. But important is first to know why they are grouped together. They are grouped together because they are having following common features. They are grouped together because they have following common features. They have got following common feature, right? So inflammatory polyarthritis, one most common cause is RA. And after that, the differential is SPA. So let's write it down, please. First common feature, SPAs are also known as seronegative arthropathy. SPA are also known as seronegative arthropathy. They are also known as the seronegative arthropathy. Right? Seronegative arthropathy is because RA factor is negative. Because RA factor is negative. Number 2, they have strong family history of arthropathy. They have got strong family history of arthropathy because HLA-B27 is positive. So we are comparing the disease with rheumatoid arthritis. Rheumatoid arthritis are RA positive and family history is not there. But in SPA, family history is there. It is there because genetic association is HLA-B27. HLA-B27 has got almost 100% inheritance. Okay, 100% inheritance. The third, primary site of joint involvement. Primary site of joint involvement is enthesitis. Primary site of joint involvement is enthesitis. What is enthesis? Enthesis means junction between bone and the tendon. Enthesis means that point between junction between tendon and the bone. Okay, last point of poor prognosis is poor socio-economic status. Poor socio-economic status and poor education is the last point of poor prognosis. Okay, come on, move ahead to the next topic, SPA. Move ahead to the next topic, that is SPA. Okay, let me finish counting, then I will zoom it for you. Axial involvement, spine involvement is relatively common. Spine involvement is relatively common and the predominant symptom is extra-articular more than the arthritis. Extra-articular. Before 100, I have written the sign approximately 100% inheritance. Almost 100% inheritance. Okay, almost 100% inheritance. Yes, Arshdeep Kaur, RA factor, range depends on laboratory. It is given in the report, no? Range is given with the report. Depends on the test the laboratory is doing. The range may vary in different laboratories. And the 6th point, it is important to differentiate RA from SPA because the first line of treatment is NSAIDs. The first line of treatment is NSAID and there is a very excellent response. Okay, so let us look at this. So we have got seronegative because there is RA factor negative. Seronegative because it is RA factor negative. SPA have got strong family history of arthropathy because it is associated with HLA-B27 which has got 100% inheritance. 100% inheritance. It is the primary site of joint involvement. Primary site of joint involvement is the enthesitis. Okay, is the enthesitis. There is no B4, it is B27 is approximately 100%. Primary site of joint involvement. Enthesitis means the junction between the tendon and the bone. Junction between the tendon and the bone. Junction between the tendon and the bone. Okay, so third point, the primary site we have written in RA, primary site is synovial membrane. In RA we have written it is synovial membrane. Okay, here it is the first site is enthesitis. Axial involvement is relatively common and predominant symptom is the presence of extra-articular symptom more than the arthritis. Okay, more than the arthritis. Very, very important point. So other symptoms before the joint pain. Recall yesterday's class. What we have written in ankylosing spondylitis before the back pain. 70% go to the opthal department with recurrent uveitis. Okay. So what's the point? Extra articular symptom presents before the arthritis. And the first line of treatment, unlike RA, first line of treatment, unlike RA, it is NSAIDs, because NSAIDs have got excellent response. NSAIDs have got excellent response. So question, when to give DMARD? When to give DMARD in SPA patient? When to give DMARD in SPA patient? Answer is simple. 2 points are there. When to give DMARD in SPA patient? Number 1, if there is presence of bone erosion on radiology. So most of the patient have to be given only NSAIDs. Most patient will recover just with NSAID. But if presence of bone erosion is there, marrow edema is there on the radiology, that time only we want to give DMARD or the new agent. Very good, correct answer. So you want to give only when there is bone erosion and marrow edema. Then only you want to consider newer agent in the treatment of SPA. So to complete our class, we are going to look at the features of individual SPA. We are going to just revise the features of individual SPA. So remember this table for me. Come on. This table you don't have to write. This table don't have to write. I want you to read it with me. I want you to read it with me. Okay. Inflammatory polyarthritis. That is the topic we are doing today. That is the topic we are doing today. So we are discussing RA and now we are discussing SPA. I am highlighting differences between the two. We don't have to write. You have already written. I am just making a table to help you remember point better. So in RA patient, if a arthritis is RA, what will you find? RA factor will be positive. Patient will be HLA DR4, DRB1, but the disease is sporadic. It is axial involvement is rare. The predominant feature is articular. Predominant feature is articular. These points we have written with RA. Now compare. When do you suspect that it is SPA? When do you suspect that it is SPA? SPA means when the RA factor is negative. When the RA factor is negative. When HLA-B27, strong family history is present. Strong family history is present. Axial involvement is relatively common. Relatively common. And extra articular symptoms predominate the disease. Extra articular symptom predominate the disease. So this is a comparative table just for you to revise. You don't have to write. You have already written it. I will post it in the club for you today as a summary of the session. As the summary of the session. Okay. So why it is important? It is important to differentiate because the treatment is different. First line of treatment in rheumatoid arthritis is DMARD. The first line of treatment in rheumatoid arthritis is DMARD, while the first line of treatment in SPA is NSAID. So if an arthritis patient comes to our clinic, polyarthritis especially, it is likely to be RA. But if it is not RA, it can be SPA. So to suspect the disease which we are dealing with, you want to remember these points because the treatment is different. Because the treatment is different. That's what is we want to understand. So check the dominant joint. Just yesterday's recall. Yesterday's recall for you today. Okay. What we have discussed yesterday. Among the SPA, SPA can be divided into axial dominant, appendicular dominant. So now we are going into the detail of SPA. Already we have completed RA. Again I am telling you, what is the indication for new agent in SPA? Either bone erosion or marrow edema. Either bone erosion or marrow edema. Indication for newer agent. Write down. So what is the point? Axial dominant. This was already done. You have already written yesterday. Already written yesterday. We don't have to write because we have already written yesterday. Just understand. Ankylosing spondylitis. Male dominant arthropathy. 90% HLA-B27 presents with low back pain, but 70% cases arthritis preceded by recurrent unilateral uveitis. Recurrent unilateral uveitis. That's what we have written yesterday. So ankylosing spondylitis. This much point is enough to know. This much point is enough to know. But we have to continue other side. So when it is symmetrical with small joint, we have studied the topic of RA. We have studied the topic of RA. But which disease looks like RA? Today's topic, psoriatic arthropathy. This is the psoriatic arthropathy we have got. This we have done yesterday. This we have done yesterday. Asymmetrical, it can be IBD associated or reactive arthritis. I am just showing you yesterday's graph. It is already in the Facebook page, yesterday's graph. Okay, so just look at the yesterday's notes, yesterday's post. You will be able to understand better. So out of that, we have completed RA, we completed Angspon. We have to complete today's class with 3 topics: psoriatic arthropathy, IBD associated reactive arthritis. That's all. So 3 pages I want you to write for today. 9:45. It will take 15 to 20 minutes depending on how fast you go. Come on, be with me. First SPA. Look in front of you. What is the problem? So what is this problem? Nail peeling. The problem is nail peeling. Image is showing nail peeling. It is called as oncolysis. Nail peeling. It is called as oncolysis. Nail peeling. It is called as an oncolysis. It 1 page each only. Simple notes I am giving you. 1 page each. Whatever is important, that's all we want to remember. Right? So psoriatic arthropathy comes with joint involvement, can mimic RA. Psoriatic arthropathy, joint involvement can mimic RA. Skin and nail changes precede the joint involvement in majority. Can precede the joint involvement in majority. But even in 5 to 10% when arthritis comes before the other feature, early DIP involvement differentiates from RA. Already all points I have written with RA. This is a summary. If you have listened RA properly, this is just an extension. This is just an extension of RA. That's all I'm telling you. RA is the main topic that we gave maximum time and attention to. This is just a differential of RA. It is a differential of RA. Oncolysis is the most common extra articular feature. Okay, so majority of the time, even though joint involvement looks like RA, before the joint is involved, they can get extra articular problem. Even if joint is involved without any other problem, it is the DIP involvement which helps differentiate from RA. Differentiates from RA. Second topic. That's all. Simple. Second SPA. Second SPA image is showing pyoderma gangrenosum. Second image, it is showing pyoderma gangrenosum. Okay, pyoderma gangrenosum, which is the most specific. It is not common. It is a specific manifestation, not common. It is a specific manifestation of IBD associated arthropathy. Okay, yes. Oncolysis is for psoriatic arthropathy. We are discussing different SPS. One of them is psoriasis. Pyoderma gangrenosum is most specific feature in the IBD associated arthropathy. What is the pattern? Remember from the approach table yesterday. Come on, we are just combining yesterday's and today's knowledge together. So what is it? Asymmetrical large joint involvement. Asymmetrical large joint involvement. But it can affect the upper limb joint. If you remember, asymmetrical has two causes. Asymmetrical can be IBD or reactive. To help differentiate between the two, asymmetrical with upper limb involvement, think of IBD associated arthropathy. Asymmetrical large joint may affect upper limb joint. Inflammatory bowel disease. Inflammatory bowel disease associated arthropathy. So even before the joint is affected, it is SPA, no? So first symptom is not joint. First symptom is diarrhea. It is preceded by diarrhea. It is preceded by diarrhea. Okay, preceded by diarrhea and associated with, this is the change in 20th edition Harrison. IBD associated arthropathy is more common with Crohn's disease. IBD associated arthritis is more common with Crohn's disease. Please note, if that last year note may be different, 20th edition Harrison change, more common with Crohn's disease. More common with Crohn's disease than ulcerative colitis. Okay, this is what we want to know. So just pyoderma gangrenosum is there in a patient with asymmetrical involvement, upper limb involvement with history of diarrhea. You will think of IBD associated arthropathy. Last topic, reactive arthritis. Last topic, reactive arthritis. Most specific feature of reactive arthritis. Most specific feature of reactive arthritis is the keratoderma blennorrhagia. Most specific feature of keratoderma blennorrhagia is the of reactive arthritis is keratoderma blennorrhagia. Keratoderma blennorrhagia are keratotic lesion seen over the palms and the soles. They are the lesions seen over the palms and the soles. Lesions seen over the palms and the soles. Okay, image is parallel. You have to only write 3 lines per topic. है ना, इससे कम notes कोई नहीं देगा. Let us be clear. So when to suspect reactive arthritis? You will suspect reactive arthritis when there is asymmetrical large joint involvement. When there is asymmetrical large joint involvement. But asymmetrical large joint तो IBD भी था. But difference is predominantly affects weight bearing joint. Reason is unknown. Why it affects lower limb? We don't know. But it affects the lower limb joint more commonly. That can be used to understand the diagnosis. And most commonly, what it is preceded by? Chlamydia associated urine infection. Most commonly, it is associated with chlamydia associated urine infection. Most commonly preceded by chlamydia associated urine infection. It can also be seen with Salmonella, Shigella, Campylobacter associated diarrhea. Yes, in reactive arthritis, lower limb joint means ankle, knee are commonly affected. Ankle, knee are more commonly affected in reactive arthritis. So the update is any SPA, any joint problem which comes with preceding history of diarrhea, it is called as enteropathic arthropathy. So any arthritis which is preceded by diarrhea is called as enteropathic arthropathy. More often than not, enteropathic arthropathy are IBD associated arthropathy. But as you can see, reactive also, some of them, reactive also can be preceded by diarrhea. Some of them are also preceded by diarrhea. That is what is the problem here. Okay. Retter's syndrome is the old name for reactive arthritis. Retter's syndrome is old name for reactive arthritis, though no longer used. No longer used. Enteropathic arthropathy. Enteropathic arthropathy. Enteropathic arthropathy is all the arthropathies preceded by diarrhea. It is a common name for all arthropathy preceded by diarrhea. They can be IBD also, or they can be those cases of reactive which are preceded by diarrhea. Now today they are all called as enteropathic arthropathy. Yes, these are the types of, these are the diseases under the heading SPA. These are the diseases under the heading SPA, spondyloarthropathy. Okay. So to complete our class today, recall the slide. So we have completed the topic. This is the last slide for recall. From the start, I am going to help you revise. Okay. This is very clearly done now. Mono and start from the full complete arthritis topic. Complete arthritis topic. Retter's disease is the old name for reactive arthritis. Old name for reactive arthritis. Come on, focus on this. Last one. Last slide. Again you have to see. Don't have to write because I am going to put it on the club. Don't write. Just read with me. Don't write. Please read with me. Okay. Now, if the patient has inflammatory monoarthritis, most common cause is trauma. Okay. Oligoarthritis, think of pseudogout. So we studied both these topics yesterday. We studied the topic gout and pseudogout. Both are green because they were the crystal induced arthropathy we studied yesterday. Then what we did, if it is polyarthritis, I will zoom it. First see, read this with me. You don't have to write. Then I will zoom it. Okay. Read this with me. So polyarthritis is there. Right? You don't have to write. Read it with me. है ना? वापस वही पूछ रहे हैं यार आप लोग. So कल हमने पढ़ा, if it is inflammatory polyarthritis, poly के अंदर दो थे. Under the poly we had two. Under polyarthritis we had two. है ना? So what is there? Monoarthritis के अंदर हमने पढ़ा gout. Oligoarthritis में हमने पढ़ा pseudogout. Okay. So we studied gout and pseudogout yesterday under the topic crystal induced arthropathy. Crystal induced arthropathy. On the other side, polyarthritis patient. Axial dominant, we think of Angstrom. Most common is SI joint, but majority present with recurrent anterior uveitis. But if it is appendicular dominant, what do we have? Under the topic appendicular dominant, we divided into two. Appendicular dominant divided into two based on whether it is symmetrical small joint, asymmetrical large joint. Symmetrical small, asymmetrical large. We had made this classification. If it is symmetrical small joint, most likely diagnosis is RA. If not RA, it is psoriatic arthropathy. If not RA, it is psoriatic arthropathy. Under asymmetrical, it can be IBD associated or reactive arthritis. IBD associated or reactive arthritis can be seen. Okay, so let me zoom it for you. So what we have got, classification. We have done, okay, that if it is polyarthritis, appendicular dominant is symmetrical with predominantly small joint involvement, we have got RA versus psoriatic arthropathy. है ना. फिर से लोग कोई पूछ रहे हैं why uveitis is recurrent, why it is sacroiliac joint. For all of them, again I am telling you, I am not angspot. Okay, I am not the disease. I don't decide, boss. है ना. Disease is like that. So focus on the clinical presentation. Why this, why not का आंसर नहीं होता है ना. There is no such answer. Pathology based, there is inflammation where it affects, that's why other disease is there. Okay, that's what we want to know. Okay, so we are going to look at this. So we are summarize this whole point together. So these are our SPA. These are our SPA. So how to differentiate RA versus psoriatic. RA में rare है DIP involvement, predominantly articular feature. Psoriatic में early DIP involvement, but majority preceded by nail and skill involvement. IBD reactive, both are asymmetrical. But how to differentiate? Because IBD predominantly affects upper limb joint. Reactive predominantly affects lower limb joint. Okay, in IBD, CD more than UC preceded by diarrhea. And specific feature is pyoderma gangrenosum. Pyoderma gangrenosum. And in reactive arthritis, specific feature is keratoderma blennorrhagia. Keratoderma blennorrhagia. Okay, so all these slides I'll put it up for you. Simple tables, go back and read. Okay, so we started with this. We completed what is important symptom in cases of arthritis. Answer, morning stiffness. I hope all of you remember. Important symptom, morning stiffness. Types of arthritis याद करिए. Types of arthritis, degenerative, inflammatory. And now we know how to approach all the cases of inflammatory arthritis. We know all the cases of inflammatory arthritis. We have studied the topic RA, SPA and crystal induced arthropathy. RA, SPA, crystal induced arthropathy. We have completed all of them, right? So this is where we end. Today arthritis is done. Tomorrow we will do vasculitis syndrome. Okay, chalo. So good night everybody. I will post these points here. Okay, and doubts, please put it under today's thread. Doubts, put it under today's thread, not on yesterday's. Okay, so that we are able to get this done. Okay, right. So tomorrow vasculitis topic.